A hallmark of PQA meetings is the active engagement of members. While we are not able to engage and be together as we have before, we're preserving that opportunity for you to share your perspective and amplify your voice. The next session here will be two commingled conversations. The first, driven by you. Share your thoughts about the SDOH interventions that hold promise for improving medication use quality and where pharmacist-provided care can have the greatest impact. Which factors do you think should be prioritized? Share your thoughts through the question and comment box. PQA staff will be elevating some of your comments and sharing them with the entire audience. The second conversation, the panel of Leadership Summit attendees and PQA members, this panel will serve as a reactor panel to this morning's programming and give us, as attendees, additional perspectives to consider when scoring a set of SDOH factors and issues. Each panelist has unique experience, perspectives, and expertise in addressing SDOH. We are thrilled to have each of them join us for this conversation today. So let's get started with our panel. Welcome to all of our panelists. We have three folks here that I want to go ahead and introduce and really get started with our conversation. So Maureen Hennessey is coming from PRECISIONvalue as the Senior Vice President, Director of Value Transformation. Libby is from PFCCpartners and is a patient family advisor. And then Helen Kourlas joins us from Healthfirst, and she is the Assistant Vice President of Clinical Strategies for Pharmacy. Welcome, everyone. I want to dive right in. So, Maureen, let's start with you, Maureen. What should manufacturers do to develop or evolve their strategy as it relates to addressing social determinants of health? What's the manufacturer's role here in addressing SDOH?
Thanks, Loren. It's great to be here with everybody today. So I think that manufacturers have some opportunities to engage with multiple stakeholders. We're talking about health plans, systems, patient advocacy groups, to address the social determinants of health and to address some of the stressors that have been exacerbated by COVID-19. And in doing so, they can expand value. They can also help close some of the disparity gaps that are glaring. They can also really help support our efforts to attain the quadruple aim. We did a survey earlier this year of health plans and health systems to identify what were some areas where they would be willing to and even interested or even currently collaborating with pharmaceutical manufacturers in the social determinants of health area. And three of the areas that really popped up, not surprisingly, access to medications, health literacy was also very prominent, as was also food insufficiency. And when you do a deeper dive and you take a look at population health management, which really is hand in glove with social determinants of health, we saw that there was a lot of interest on the part of health systems and health plans in collaborating with pharmaceutical manufacturers on helping patient members to manage side effects, helping promote medication adherence, and also patient engagement kinds of initiatives, whether those be person-to-person or whether they be more virtual in nature. And the other thing that I think was really striking was that they said that they were quite willing and very interested, in fact, many of them, in collaborating on crisis management initiatives during COVID-19 and also on other crises, because they see this, unfortunately, as perhaps the tip of the iceberg of some of what we're going to be dealing with for a while. And so with that in mind, what I would really suggest, Loren, is that manufacturers, in a very systematic, very comprehensive way, really do a review of their strategic and tactical initiatives to address social determinants of health from the very beginning, whether you're talking clinical trials all the way through launch and patient assistance programs on an ongoing basis. And I can give you some ideas in terms of that. So, for example, when you think about clinical trials, many pharmaceutical manufacturers will collaborate with patient advocacy groups. And those patient advocacy groups, particularly now, can be such advocates in terms of helping you as a pharmaceutical manufacturer to think through where are the social determinants of health particularly adversely impacting your patients or your potential customers. And then what they can do is to strategize to address those social determinants or social risk factors, and even serve as ambassadors for you in some ways in addressing some of those issues. Likewise, I would also say that it becomes really important to take at how you're interacting and using your patient assistance programs for patients, particularly now when people feel so which is one of the hallmarks of this pandemic. It was also referenced this morning by some of our speakers, by Laura and Dr. Jane. And so from that perspective, we can do things like we can better promote our patient assistance programs. There was some research done last year or so on that something like 2/3 of patients, particularly ones with conditions or complex conditions like cancer, would be very interested in participating and connecting with patient support services offered by manufacturers. Yet, only about 20% of the surveyed respondents said that they even knew about these programs. And so working back, pharma can work back with key stakeholders, whether it be health plans, whether it be patient advocates, your own patient assistance services, to promote these programs, and then further to really take a close look right at how your patient assistance teams are addressing social determinants of health, not only in the area of access to medications, which is vital, but also are there other that they can potentially link patients up with services for to help address the needs that they may have that are obstacles to health. We'll talk a little bit more later, if you like, about the issue of the culture of science and messaging and who are your optimal messengers, if you like.
Absolutely. You've mentioned patient a number of times, and obviously when we're considering SDOH, we're certainly focused on the patient. And I want to bring Libby Hoy in here. As a patient family advisor here, Libby, what's top of mind for those patients? You've heard Maureen mention there are plenty of patient assistance programs out there, but how are we getting these connected? How do we get these connected to address SDOH?
Great question, Loren, and thank you so much for having me on this panel. I think the fact that PQA has invited a patient and family caregiver to participate in this panel is just such evidence of the determination of this community to really address social determinants of health. And funny, as Maureen was talking, I grabbed my pen to make a note to connect with Maureen to have her speak to our patient and family advisory network so that we do promote those services. I was just thinking last week as I went to my local pharmacist, and the pharmacy tech actually said, you know what, I think there's a program for this, and I hadn't even really researched it. So I think we do have some more work to do there together. And I think together is the point I want to drive home really loud and clear. And you mentioned that I come to this work as a patient family advisor, as someone who's raised 3 sons living with mitochondrial dysfunction and survives stage 4 salivary gland cancer myself. And it's that perspective, I think, that we want to continue to partner with organizations like PQA and all of its members to authentically bring that voice forward in partnership to co-design the solutions that we all need. I think I wanted to share that early in the pandemic, through our work with Los Angeles County Department of Health Services, we've been engaged with them for about 2 years now to authentically engage the residents of LA County into the health system, into its quality improvement initiative specifically. And so early on, we were tapped to get together with our community here in Los Angeles County and find out, what are people worried about most and what's top of mind. And across the board, it was, how do I get my medication? What am I going to do if I can't get to the pharmacy or the pharmacy's not open? And so I think we're very, very much in good alignment that this is a critical nature. So I'm going to reference the PFA network a couple of times during my comments, so I want to make sure everyone understands. As part of our organization, we support the PFA network, which is about 620 people like myself who are using their lived experiences in the healthcare system to influence it, be it with research partners, quality improvement programs, health systems themselves, and newer into the mix are payers and measure developers. So through that, and early on to combat some of the isolation that's been mentioned several times today, we stood up Friday morning coffee chats. So anybody who was feeling isolated in our community could just log in on Friday morning. It was just a chance to connect. And we really did that because we were concerned about some of our senior population, in particular in our rural populations, feeling that sense of isolation. But what has gone on since March, all the way through, is we've gotten this incredible glimpse into how communities across the country are experiencing the pandemic, and again, how they're experiencing access to care issues, including medication and staying on their typical protocols. So I'm just, again, really happy to think about PQA's commitment that as we think about access and medical programs, that we're doing so in the context of people's lives. So one reflection I wanted to share as I listened to Dr. Jane this morning speak about the health desk that SCAN is setting up to meet the needs of the senior population who may have limited virtual access or virtual competency. And so I think those kinds of efforts are really key to continuing the conversation, continuing the relationship with people who are trying to navigate this pandemic and this healthcare system. We hear from members of the PFA network, again, across the country, that people are using their influence and their connections across the community. So that's a point I wanted to kind of think about together. How can we really connect with our community members and allow them to be the connectors across communities? I think the community-based pharmacist, again, has, when I think of mine, it's essential piece of my team, right? And so how can those community pharmacists be catalysts for those and connecting points along with your patients and your family members that you're serving? So what we've heard in terms of the virtual divide is a couple of encouraging pieces, I think, and then also, of course, some areas that we need to address. Some of the encouraging areas are the quality of virtual visits and the ease of virtual visits once we kind of get folks over the hump of getting on that first and transitioning into a virtual world. We hear about convenience. We hear about cost savings. We had one mom who took her daughter for usually took her daughter for their annual neurology check-in, and that usually consisted of a 2-hour drive each way and considerable stress for her daughter who experiences disabilities. And in the virtual visit, she felt like was a better quality visit because her daughter was in her home setting and her baseline was more accurate than it was. So there's all these kind of wonderfully maybe non-intended benefits to the virtual world that I really want to keep focus on, because I think patients and families are really appreciating that aspect of it, even while we acknowledge the challenges of some communities to access. So what we've heard, particularly in our rural communities, is unique partnerships in the communities. For instance, one community in Iowa partnered with their education system, their school district, to sort of piggyback onto all of the wire that was getting laid for the education system, and then how they could make those connections. So they were working together with some of those unique partnerships. And so I think, again, as we think about what the community pharmacist and the patients and families have in common, is that relationship base and ability to be connectors across their communities.
Excellent.
So I really appreciate the tremendous efforts to address social determinants of health presented here today. I think clearly PQA members understand the connection of social determinants of health and a patient's ability to access medication. As a patient-driven organization, we're expanding our own thinking about how to establish equitable health outcomes. I will say that we've been on a learning journey ourselves over the last 6 months, both with our PFA network members, particularly the PFA members that are represent the Black and African American community. And what we've realized is that although inclusivity has always been a core value of ours, and we always included anyone who came to our door, what we've recognized is we don't have enough doors and they're not in the right places. So we really need to expand how we move forward with creating more opportunities in the communities. We've really come to believe that communities have the best knowledge of the issues, right? The local solutions are those that are going to get us the furthest. So they have the best knowledge of the issues. They also have the skill set to solve them. What they don't have are the resources. So how do we think about how we sort of democratize the resources across communities, engage community-based organizations, engage partners that we haven't traditionally done to really get to identifying the priorities, local priorities for social determinants of health. I think our goal is to standardize an individualized approach to care, including access to medications.
Excellent.
I also want to mention the impact of patient-family advisors. So again, those of us using our lived experience to influence the healthcare system. We've largely been sidelined during the COVID and pandemic response. And of course, in the initial days of the response, we enacted our incident command centers and had all of those protocols in place. And that really quickly sidelined our patient family advisory councils in our health systems, in our research teams, even in our quality improvement work. And so I think it's important to continue to create those connections, and Maureen referenced those as well. Connections with the people that are being served, so that together we can really identify, again, what are the priority determinants of health in a specific community and how can we best address them. I think one of the early, I heard mention of developing a screening tool. So as we think about screening tools, I think if we create a standard screening tool across the pharmacy world, one thing we might want to think about is how do we build in the flexibilities to become a local support? And then how do we build in the opportunity and really create the infrastructure across our organizations that allow for the consistent and continuous feed of the patient and the family member into our programs? A screening tool is an excellent place to start with this. So bringing in a group of local community members. In fact, we did this recently here in Los Angeles. We had a researcher who was working on a vaccine come to a patient family advisory council and say, we really want to test this. We need to test it in the African American community here in Los Angeles. How do we do that? Here's our flyer. And we had some of our African American residents in the meeting and say, if I read this flyer, I'd go running the other way, because it didn't really address all of the history that we have here in LA County in our African American community. And so those kinds of really brass tacks, I think, can increase our efficiency of these efforts. They can increase the effectiveness of these efforts and really get us towards meeting the needs, the social determinants of health. So I'll leave it there for the moment, but I have a whole lot more to say.
Well, I have, thank you very much for joining us and sharing all of that. There's so much. I've been feverishly taking notes of points that I want to kind of revisit and definitely connect amongst our panelists here. And one point there, that the initial question was, where are the patient's heads? What's the patient's priority? And it was, how do I get my meds? And it comes back to one of the comments that was shared from our audience that says people often underestimate how critical food security, homelessness, and social isolation are to medication adherence and healthcare utilization, especially now. So thank you very much for those relevant comments that Libby has integrated in, and our audience are all on the same page here. Another point I want to revisit and then bring Helen into this conversation is really, Libby mentioned a mother that was looking for that convenience and cost savings. And so Helen, as working with a health plan that's based in New York City and has a pretty close relationship with the population there, as well as with the community pharmacies. What social determinants of health is a health plan interested in offering to be conveniently addressed at the community level?
Great. Thank you, Loren. Thank you, PQA, for giving me this opportunity this afternoon to speak with all you. Really excited to talk about this topic. We are very close to this topic. As you can understand, we are based in New York City, so we have a very close pulse on what is happening within our community and within our membership. What we realized during COVID, obviously it bubbled to the top, but what we continue to really understand is that the reason why our members, our patients, are non-adherent to their medication isn't because of really solely the medication. It's about other things that are happening. And we realize that our food insecurities, housing insecurities, health literacy, not being able to really understand the severity of their disease, and that these are medications that need to be taken chronically in order to avoid further deterioration of their condition or just ER visits and inpatient hospitalizations. And what we've realized is that working with our pharmacies and our providers is that our members, when they are visiting and these very very accessible outlets. For example, the pharmacy is located in the communities that our patients live in. They speak the language that our members speak. They find comfort in knowing that they share a culture, a language, and so trust is built. And so the community pharmacists are the ones that can really assist in these various issues as it relates to food insecurities. They can direct members where there's a food bank, housing insecurities. For example, also, what are some ways that they can sign up for various city programs in order to have other costs covered? For example, water bill, their electric bill, things of that nature to offset the cost of them to stay on their medication, because obviously there's some copays associated. At Healthfirst, we have a great team of individuals that is headed by one of our medical physicians, and clinical partnerships has taken a real front and center role in partnering with our providers in our communities. And again, the providers are in these communities where our members live and breathe. And so during this time, they've been able to identify, what are the barriers to them to getting their medications, staying on track, being adherent. And essentially what we've provided are tools in order for them to guide their members, patients, to several solutions. However, what we found is that it can't be a one-way conversation. We've realized our members have a very difficult time navigating the healthcare system, Healthfirst in general, or just general life in some instances, depending on what they're experiencing. And so some of these services allow for there to be patient navigators that work with our patients in order to guide them to solutions that fit best for them, and then really just allow for that follow-up. And we're really excited about it because it takes away from that one-way conversation that we would potentially have if we were posed with an issue that our member is communicating to us and say, well, you can go here and there and possibly get a solution. This offers an alternative where we're closing the loop on potentially what the issues are. So it's really exciting, and Healthfirst has a real big footprint in the community. We're really excited to work with our providers in order to allow them to have access to different types of resources and platforms for them to access when they are faced with members that vocalize these different types of issues as they relate to their health. The last thing we need is for them to worry about when they're getting their next meal. And so by providing all these services, we're able to keep them on track with their medication, which is really, what we're focused on, and really work with our pharmacies in order to do that. So I know we've referenced COVID. Obviously, it was a huge occurrence for all of us to navigate. It was very difficult, and we heard the same. How am I able to get my medication? And so what we found is that community pharmacies were doing their best. However, the provider offices, because of issues, were closed. And so because of that, we needed to rely heavily on our pharmacies, and then looked elsewhere for other types of pharmacies within our community that is able to do the delivery. Many of our members were afraid to leave their homes in fear of COVID. So we needed to provide some alternate methods for them to receive their medication, whether it's through delivery and through small pilot programs of offering a courier service. So we found that that was an issue that rise to the top during COVID. We really tried to encourage our members to vocalize whatever issues were happening. We were doing this very intimately with some of our member communications, especially with our pharmacy technician outreach program that we have in place to help with STARS. But during COVID, it was really centered around, how are you? What's going on? How can I help you solve whatever issue that you're having? And our techs were able to navigate different platforms that offer solutions to help. But again, they found themselves really just trying to connect the dots to offer various solutions and really help the member, because we realized they can't do it on their own. So during all this time, we really come to realize that looking for solutions around social determinants of health are really standing with our members, with our patients, and ensuring that they do receive the right type of assistance that will solve or somehow guide them in the direction where it's not an issue for them and they can focus on their health, staying adherent to their medication, and really staying out of the hospital. So that's what really we realized during all this time, is that sometimes it needs to be a white glove service. And if we do it now and we're able to help our members, then hopefully they can take that lead on their own to reach out and find those solutions.
Absolutely, absolutely. Thank you very much for that, Helen. Again, we're connecting so many dots here between our panelists as well as the audience comments. Bubbling to the top here is proactive SDOH screening with local resource referral is key, and community pharmacy has a great opportunity here. I heard numerous times from Helen about those resources, giving those resources out to that community, into the community with those providers that have the relationships. Another thing I heard from Helen here is related to health literacy and a language and a culture. Maureen and I were preparing for this panel a few days ago, and during it, she mentioned the culture of science, and she mentioned it earlier in our panel here, and I did the typical pharmacist motivational interviewing tactic, and I said, tell me more. So Maureen, tell us more about the culture of science and how it all relates here to SDOH and addressing SDOH and these resources.
Sure, thank you. When I think about the culture of science, I would say that the average person is not all that bonded with the culture of science. What we bond with as humans is we bond with people who we think are accessible to us, people who we think we can trust and who genuinely want to try and help us with our concerns, very much like what Helen was talking about earlier. And we bond with people who we think will be pragmatic and practical in helping us solve our problems. And so what that means many times is that it's the boots on the ground, so to speak. It's the person who's maybe on the line, who's the patient assistance provider. It's the healthcare worker in the community. It's the local community pharmacist, or the pharmacist maybe on the PBM, or maybe on a care management phone line. It's those people who are directly interacting and connecting with patients, who very much, I think, are messengers who can not only potentially help with the social determinants of health, like getting access to our medication or getting connected up with a food bank or getting somebody to deliver us groceries, but are also the people who can be trusted by patients to actually help them better understand their medications and to have trust in the therapies, the vaccines, the personal hygiene and other initiatives that we need to take so that we can contain COVID, and also the medications that we need to be taking on a regular basis to manage other acute conditions or chronic conditions. And I think it's really important. Somebody this morning talked about the fact that training is sometimes needed to help with that. And I think that's really right on. I think motivational interviewing, tips and tools can be very helpful. I also think actually shared decision-making tools and training can be very helpful as well. And part of the reason why I say that is because different people respond to different kinds of messages. And I think really researching the patients that we're helping, understanding them from a demographic perspective, from a social determinants of health perspective, from a psychographic perspective, what are their attitudes, values, and needs regarding self-care? All of those things become very important, and it becomes vital for us to research that and also to help support the people who are interacting daily to help address social determinants of health, to have messages that are going to resonate with their patients. And different patients, as we all know, resonate in different ways. One of the speakers this morning was talking about the different kinds of circumstances that people might run into and how you might help different patients differently from an SDOH perspective. And what I would say is think about, for example, the individual who really is very balanced. They want to get all their information from multiple sources, and they want to really decide for themselves what's best for them. That kind of individual might respond very well, for example, to shared decision-making and to messages about their condition and therapies that helps them to be able to balance what's best for them from their perspective. Another patient might be someone who thinks of themselves as invulnerable or invincible. They want to do what they want to do now when they want to do it, and they're not necessarily real open to behavioral change, or particularly when it comes to their health behaviors or some other behaviors. And so that kind of individual might do very well with motivational interviewing, where one isn't pushing against them or arguing against, trying to dispute their beliefs, but rather helps them to tap into their motivations, what's most important to them, to motivate them in some way to make some changes in their health behaviors. And what I would say about that is that many times the influencers, the social influencers that someone was talking about earlier, may be the people in my community who are health workers, or my local community pharmacist who I also see at my kids' baseball games. That's the kind of person who may be most likely to influence me. And further, it may be my family members, so I might be more willing to change my behavior, not so much because I'm really concerned about myself, but more because I'm concerned about my family or how something that I'm doing may impact my family. So thinking very carefully about how we approach patients and giving additional tools for the various community pharmacists, healthcare workers, care managers, and so on can be very important, and also supporting them, equipping them with the messages that are going to have the greatest resonance and connection also becomes important as well. Particularly if we're going to address the infodemic that we're dealing with, where there's a great deal of misinformation and mistrust, unfortunately, about various therapies.
Absolutely, absolutely. And again, connecting in our audience comments here, Maureen, you mentioned those tools and the training. There's also this great desire to standardize a screening tool for SDOH across healthcare settings. And then, of course, we are needing to allocate resources to identifying and prioritizing where resources can be applied best in this space. I think that very much aligns with what Helen was speaking to us about. And so, kind of as we continue to look at our comments here, a tool to identify local resources for addressing social determinants of health, which can be different geographically, would be helpful. Again, hearing from that call that Helen has certainly addressed, and very much what's on the forefront of patients' minds there. So as we come to the end of our time here with our panel, we've covered so many topics, and I want to dive into so many, but we're unfortunately limited to time. So as we're wrapping up here, starting with Libby, tell us, Libby, SDOH is a huge, very broad topic. We have talked about a lot. where do we start? The resources are are limited by the different stakeholders that are in play here, but where do we start? Libby?
Great question. And so I think the good news is you don't have to do it by yourself. And the good news is you don't have to, your starting point may not be the community starting point. And what I mean by that is there are organizations in your community that address food insecurity. There are organizations in your communities that serve the homeless. There are those, what the first steps are is partnering with those organizations. I think the community health needs assessments are a really underutilized tool in that arena. So, you know, pulling those up and dusting those off and seeing what is in your communities, and then really extending. So I think that's what the first step. I think extending yourselves into the communities and recognizing all of the good work that's going on. You know, we're fortunate enough to work with a family resource center here in South Central Los Angeles, an area that with our best of intentions, we wanted to go in and get people engaged in their healthcare, but had to recognize that we didn't have the credibility, the trust that's pivotal in community work, trust. And so we didn't have that. We needed to partner with those trusted community members, and certainly the pharmacists are essential in that. And so I think looking at who's in your community and then partnering and then building the infrastructure again to be continually informed by the patients and families that you're serving. I think that's critical. So giving resources, putting it into your organizational structure, really moving from feedback into continuous feed so that together we can really build the community around those social determinants of health. And, you know, I just would love to mention really quickly how critical language is. You've heard from it in terms of culturally how people want to be approached in the language that resonates. But I will say that by and large, across our PFA network, as diverse as it is in different regions of the country, the term adherence is really loaded. It's very loaded for us. It's a very, if you ask me, you know, are you adhering to your medication? Well, yes, of course I am, because that's what I'm supposed to do, right? There's a power differential. And so that's just one example, but you've heard me talk today. I haven't used that term yet. I'm talking about access. And so I think that's one of the very first steps that patients and families can really help health systems and organizations with, is just getting down to, let's get some common language so that we can move forward together really effectively.
Excellent. Helen, same question. Where do we start? Where do we start here?
So I think being from New York City and having such a huge, living in a cultural whirlwind of different types of languages, people's backgrounds, I think for services to be adopted, to be utilized, need to be tailored specifically for those types of individuals in order for them to trust that those types of services will be of assistance to them. What we've also understood through some of our community work is that, you know, our members get a lot of their information from non-clinical areas, like their church group, the barbershop, you know, when they go to the supermarket with their girlfriends and they're talking about different types of therapies on, you know, treating X, Y, and Z. So understanding that individuals will seek different types of alternative methods of treatment from non-clinical folks, and having pharmacists and providers that are close to that culture can speak to members and patients about that and identify with it, and through that come with really a member-centric solution that is something that the member patient will commit to and follow through and utilize as a resource to solve whatever the issue is, because it's something that the member feels comfortable to actually execute on. So to have that balance, I feel is key. The member has to buy into it, right? They have to find what's in it for me in order for it to solve whatever issue that I'm looking for. And really having the guidance of our health professionals in the community that can relate to it, again, builds that trust in order for members to then keep coming back
right? And that's what we want. We want patients and our members to be engaged in their health journey, to really seek for guidance when they need it and know they have a trusted healthcare professional that will guide them in the right direction.
Excellent. And Maureen, here in the final 25, 30 seconds before we have to transition, where do we start from your perspective?
You bet. So as I think about population health management and the incredible amount of needs that we have, a key piece of it is how do we make it precision population health management? And analytics becomes very important. Finding the individuals, identifying the individuals by their key therapeutic areas or disease states, and identifying what are their specific, most pressing social determinants of health needs. So that can be done through analytics. It can also be done through screening, and it can also be done through contact with people who are in the community. I've heard a lot of talk today about the people in the community are the people that you're most likely to resonate to, and I think that is just so important. And I've also really want to talk about messaging as well and how important that is. And Libby really drove that home when she spoke about the issue of adherence, that adherence is not how people typically want to, that can be sort of a guilt, it's a clinical term, and it can also sort of be a guilt-tripping term if you happen to be talking to a patient or a family member in that way. It's more like, gee, how are you doing with you know, are you having those side effects that you used to have, you know? Are you still having, you know, the heartburn? You know, those are the kinds of questions that are useful as opposed to, are you being adherent? So I think there's adherence, can be approached in lots of different ways. It's through that connection that we have. It's through the messaging, the types of phrases and the types of questions that we ask. That's where motivational interviewing comes in. And I would also say that telehealth is a whole new technology that we can really leverage as well in helping patients to be able to use it too.
Well, I want to ask Richard to push us back 2 slides because one of the audience comments that came in regarding the pharmacist in addressing SDOH, because it's immediately relevant and excellent transition to our next session. But I want to first thank our panelists, Libby, Helen, Maureen. Thank you all for joining us and lending us your perspectives. We encourage our audience to continue to submit comments and questions to us. We want to hear from you.